my name is Tiara Bridges, and today I'll be performing NG2 placement and NG2 removal. First thing I'll do is gather my supplies and check physician's orders. Then I will go ahead into the patient room and check the ordering against the procedure card. Then I will go wash my hands and put on gloves, clean gloves. After I put on clean gloves, I will place my patient in high flowers, and unless it's contraindicated, and I will make sure I have like a basin emesis to where just in case they do have something that comes out after, and now I have ice chips just in case they have a difficulty issue with swallowing. Then after that, I will go ahead and put a drape down on my patient, and this is my patient, making sure that in case stuff comes out of the nose or the mouth, then it won't get on the patient. Then I will go ahead after that. I will go ahead and check the patency of the nose, and in case I want to use this nose nair right here, I will go ahead and close one side of the nose and ask them to make sure that they can breathe. And if they can breathe, then I know that this nair is great to use. Then after that, I will go ahead and measure my NG2 and I'm going to demonstrate on myself so you can see how I do it, by starting right here where the nose I'm going to go, then go down to my ear, and then after that, I will go down all the way to my Ziploc process, and then I will place a tape, piece of tape where I want to stop at. It's kind of tedious. And then after that, I will go ahead and get my lubricant and place it in the container. And then I will lubricate it from 4 to 5 inches. And after I lubricate it, I will go ahead and insert the tube. And I will insert the tube in the nair that the patient was able to blow that I'll use to test. Then I will go in. If my patient have issues with coughing, cyanosis or whatever, I would stop it. But if not, then I would keep going all the way down to the Ziploc process. After I stop at the Ziploc process, I will know based on this piece of tape where I'm stopping at. And then after that, I will go ahead and secure it partially. But then also, ways that I can verify is by aspirating or even having a chest x-ray. Once I verify that the placement is correct with chest x-ray, then I will go ahead and tape it to the side of the face, making sure that it does not come out or anything. And then after that, I will attach it to either the feeding pump or even the suctioning. After that, I will go ahead and take off my gloves, wash my hands, and document. I will document the size of the tube, which is, and the type of the tube, which is 14 French, and then I will go ahead and document my patient response, and then I will document the nair that I use, whether it's right or left, and then I will also document that I verify the placement with the chest x-ray or the aspiration. Then after that, I will move on to, in case I want to remove it, I will remove it by checking a physician's order and asking for my patient's identifiers by checking name, date of birth. Then after that, I will wash hands and put on gloves. Then once I put on gloves, I will disconnect it from the feeding tube that I had priorly and also the suctioning. After I do that, I will explain and make sure that my patient understands that they need to hold their breath and that I will slowly remove it. So I will take the tape off, ask them to hold their breath, and then I would remove it by slowly and steadily taking it out and After I take it out, I would dispose of it properly, and my patient will have the drape down already, just in case anything comes up out of this. And then after that, I will go ahead and provide oral care, and even nasal care by cleaning it with a towel or just not soapy or anything. And then I'll go ahead and remove my gloves. After I remove my gloves, I will document that I removed it, the time I removed it, how my patient had tolerated the actual procedure. Okay, next we'll discuss the feedings with the patient with an NG tube. First thing I would do, I would check the MR and check the physician's order. I will go ahead and check the allergies while I'm also in the computer, and then go to the patient, explain the procedure, ask for the two identifiers, which is the name and date of birth. Then after that, I will go ahead and perform hand hygiene, and then by washing my hands, and then also I will go ahead and put on gloves. Okay, after I put on gloves, I can go ahead and start preparing the feedings. And the first thing I would do is get the feedings, which is the can, shake the can up to make sure it's shaking evenly. And then I will go ahead and open it up and open up the bag and pour it into it based on how much the doctor wants the patient to have. Then after that, I will go ahead and prime the tubing by holding it up and then letting it flow down to the tip. And once it flows down, then I can close it. Then after that, after I go ahead and do that, I will connect it. But first, I will go ahead and check the pH, and then check the residual by pulling back, seeing that it's 250 mLs, which is good. But if it's more than 500 mLs, then I know I need to stop and I do not need to proceed. Then I can go ahead and flush it with 30 mLs of water, and once I flush that, then I know I can go ahead and attach the two. Once I attach the two to the feedings, then I will go ahead and turn it on. Once I turn it on, if it was a bolus feeding, then I will go ahead and let it flow down to gravity, and then I will flush after with 30 mLs. If it was an intermediate feeding, I will flush 30 mLs before and after the feeding. Then after that, I will check residual every 4 to 6 hours depending on the hospital policy. And then also I will change the tubing and the feeding every 24 hours. Then after I would do that, I will go ahead and check the insertion site by looking at it, making sure there's no redness, no breakdown, nothing that would cause the feeding not to flow through, making sure the nose is still patent. And then after that, I will go ahead and document if there's nausea. If there's nausea, I will go ahead and talk to the doctor and see what's the next action. Then I would document how much feedings I gave and what type of feedings. Then I'll go ahead and document the residual and making sure that no more than 250 mLs is still coming out. And then also I would check, make sure that I've mentioned that I assess the patient by checking for redness, breakdown, and then after that, then I know that I can continue the feedings, and that is the feedings for NG tube. A reason to where I would have to suction a patient with the NG tube is when there is a bowel obstruction that's suspected, and then I will go ahead and suction and make sure I take a sample of the contents and send it to the lab for testing.